They're peds, so I've done a lot of stuff, and then I landed here in the ED and fell in love. So that's where I am now. And please welcome one of our staff nurses. This is Courtney Abatiello.
Hi guys, my name's Courtney. I've been a nurse for 6 years. I started here in the ED fellowship 6 years ago when I was a new grad. I love peds, so I hopped over to Cohen's for a little bit and then made my way back over here. I'm the pediatric care coordinator in the ED and also co-chair of Collaborative Care Council. I like to be very involved, so I'm happy to be here, give you a little bit of perspective from my side of things as well. So I hope you enjoy and learn something.
So welcome. Our presentation is basically just about our department. Every one of you in other floors gets patients from our department. They usually start down by us. And I feel like it's nice to have some perspective of how our department flows, how our team works together, how our patient becomes stabilized before they come to where you get them, what our day looks like, what our department looks like, all the different interdisciplinary teams that we work with down in the emergency department. We'll talk a little bit about our fellowship, about our statistics, and then we'll do a little presentation on one of our devices that is maybe unfamiliar to other faces who have never seen it before because it's only really used in EMS and our department. And then we'll leave time for questions. So a little about our department. We love to talk about our accolades because we have many of them. So we are American Nurse Association Lantern Award recipients twice in a row. So anybody who's not familiar with the Lantern Award, it's for excellence in emergency department care. So similar to what a Magnet Award is for a hospital, this is our emergency Magnet Award, if you like to call it that. So our team writes this document for the Lantern Award, including all of our statistics and all the great work that we do every day. It's read anonymously. They don't know what hospital it came from, and then the departments are given the award. So we're happy to say that in 2024 we were the second time recipients of our Lantern Award. Our emergency department also does a lot of strokes, I'm sure. If you're in the building at any point, you've heard overhead that there's stroke alerts. So we are a Joint Commission certified comprehensive stroke center. We are an American College of Surgeons verified level 1 trauma center, and I'll talk a lot about trauma later on. We are an ACC sexual assault nurse examiners program here in the department. We have some nurses that work with us in the department, such as myself, who are SANE certified. And then we also have flex nurses that come in when we do have sexual assault patients. And then we are American College of Emergency Physicians Geriatric Emergency Department, and we got the silver accreditation just this year. We are the first Northwell hospital to receive silver, so it's a big deal and a lot went into it. You'll see on our next slide our statistics. We have a large geriatric patient population. So our emergency department is made up of 72 patient beds. Does that mean we can only hold 72 patients? Absolutely not. We have over 100 patients at a time sometimes, depending on our census. We have hallway beds. We have just people everywhere. This is all statistics from 2024, so last year's statistics. So we had 79,937 total visits last year. We just got our numbers for this first quarter of this year, and we saw 25,000. So it's looking like we're heading towards that or even more this year. Out of that 79,000, we have about 31,000 that are geriatrics. So it's a majority of our patient population is the growing, aging adults. That's why it was super important for us to get that silver accreditation to show the great work that we do for our older aging population. We had about 2,600 pediatric patients this year. As you know, we don't have a pediatric floor here anymore, but that doesn't mean that we don't care for pediatric patients. So we all have PALS certification. We see our pediatric patients as they come in, and then we stabilize them and either transfer to Cohen's or we send them home. We also had about 1,000 psych patients. This psych population has definitely grown over the last few years. There are times when we have 8 one-to-ones at a time in our department, and that's not abnormal for us. And the way that we handle psych patients is very different than any other floors or areas. We hold them for sometimes a couple days, depending on where they're destined to go, because we don't have a psych floor again upstairs. So we had 234 level 1 traumas last year, 157 level 2 traumas, and 379 confirmed strokes. That doesn't mean that that's the amount of stroke alerts we did call, because when patients meet criteria, we do call a lot of strokes. I feel like we call 379 in a day. That is our confirmed strokes. But we do call a lot of them, and we'll talk a little bit about our process for what a stroke alert looks like in our department as well. All right, so we'll start with a little overview of our workflow. Our workflow is extremely different than any other department because we're considered outpatient. We see patients off the street coming in by ambulance. So we have walk-in triage where you brought yourself, your family member took you in, and then you meet our triage nurse, our registration, and we kind of hear a little bit of the story of why you're here. Patients also come in by EMS, by ambulance, and then also by helicopter. So I'll talk about our code aviations and our code sky health a little later, but those are the 3 ways of transportation into this facility. Once a patient gets to our facility, we need to understand their acuity level. So we use the EMA's ESI, Emergency Severity Index leveling system, and 1 being the most severe, life-threatening, up until 5, which really doesn't require any resources. So that's how we choose the level. Our nurses go through a triage class where they're taught on, what a resource is a resource. How many resources do you foresee this patient needing while they're in the department? Also taking into consideration vital signs and, a quick visual assessment of our patients. So each patient is then assigned an ESI level. And when they get that level, it kind of determines how they come into the department and which part of the department they go into. We have a lot of patients waiting in our waiting room at times. We do have a really great process for getting people back fast. But you'll often hear people say, like, I was here before them. Why did they get to go in before me? And it's hard to clarify that that's not how it goes in the ER. You're actually better off if you're going in last. If you're rushed in, that isn't a good sign. So this is how we decide who goes in before who and what actual assignment is. Then we have a clinical evaluation. So the patient is slotted for a certain area and the clinical team will then do their assessment. So the nurse, ancillary, will get them on the monitor, whatever they need to be set up. And then the nurse will do their evaluation as well as one of the providers. Once the providers see the patient, decide what they need to decide what their diagnosis is, right? Because then we're trying to find out, what is going on with this patient. We have diagnostic testing and we have X-ray, CAT scan, ultrasounds, all in our department. So we have an ultrasound team. team of residents that train down with us in the emergency department. So we have ample amounts of ultrasounds machines all over, and we can do the ultrasounds at bedside. There are some ultrasounds that still go upstairs and are read by radiology, but a lot of our ultrasounds can be done at the bedside. And then MRI is the same MRI that everybody else uses. To not do MRIs that often, as most of the time they're not emergent. However, we do use it for certain circumstances. We use it for wake up strokes and other diagnostic testing. Then treatment is decided. Obviously, we're always going through the nursing process. So, you know, we're doing our assessments and deciding on interventions, and then treatment is put in place. And then we have a disposition. So what is the patient's plan of care from there? So are they going to be discharged home? How are they getting home? Are they going to be admitted because they need further assessment, further treatment? Or will they go to our CDU, which is our clinical decision unit? So our clinical decision unit is our observation area. It's part of our emergency department, and it's for patients who may just need, you know, one test that may take hours to actually get. So we put them over in our ob area and in the hopes that it'll be less than 24 hours stay. And from there, they can either be discharged or they can be admitted if necessary. All right, so I'm going to ask Courtney to come up and talk a little bit about our team dynamic and kind of the areas of how we put patients in our department.
So, show of hands, who has been down into the ED? Okay, a lot of you. It's huge, right? It's like a maze. You probably got lost and had to ask someone for directions on how to get out. That's exactly how I felt when I first started as well. And it's expanded over the years and gotten bigger and bigger to where it is today. So we have several different areas, like Diane mentioned. So there's green, gold, purple, red, pink, blue, red north, orange. There's also navy, which is not blue. It's different than blue. That's holding. But I'm going to just go through quickly the areas and what kind of patients each area sees. So green, you might think that's like a fast track, but it's the opposite. Green is the critical area. That's where you probably walked into that first big hallway where we have our 4 trauma rooms. We also have a few hallway spots, psych rooms, as well as 4 smaller rooms that are just to the side of it. So the green area, because it has those trauma rooms, is where all of our traumas will go. It's where people who come in that are very unstable, maybe they're in cardiac arrest or we think they might code, anyone who comes in looking like they might require intubation. That's like your ESI level 1s or 2s that are really sick and require a lot of attention right now. Gold, purple, and red are similar areas in terms of the patients they see. So those are typically level 2s and 3s. So a lot of chest pain, abdominal pain, back pain, things like that, where they need an IV, lab, some testing, but they're not as sick. Doesn't mean you can't get a sicker patient there. We just try to keep those ones in green. Blue used to be our fast track area. Now it's what we have called quick doc or QDoc. So we have patients that are in the waiting room that we'll bring into there for a rapid evaluation by a PA or one of our doctors. They'll get an IV, labs, some basic meds, and some testing ordered while they're waiting to be slotted for one of the main areas where they'll get a more comprehensive evaluation and finish out their care. Red North is now fast track. So that's your more urgent care level patients. So maybe a laceration, potential broken bone or sprain. It could also be some of what we call softer 3s. So maybe someone who's young with urinary symptoms that might need an IV and some blood work, but is walkie-talkie and can kind of do things on their own. They're not requiring as much total care. And then orange is CDU. So that, again, is the observation unit. So the patients who kind of need some more testing done but don't require a full admission, shorter term stay, we will have them there. The department has changed a lot over the last several years, especially since COVID. We've become very flexible and dynamic with which area is which. Like I mentioned, blue used to be fast track. So we will often pilot programs where we change the areas up a bit to meet the needs of the department, the overall community. Like when COVID happened, we changed it a lot. So depending on what's going on, the types of patients we're seeing, the volumes we're seeing, we adapt appropriately. In each area, there will be nurses. Depending on the area, some areas are larger than others. You could have 4 nurses, maybe 2 nurses or 3. And then you'll have your provider. So there's an attending, usually a couple residents or NPs or PAs. So you also have ancillary assigned to those areas as well. Again, depending on the size, you might have 1 or 2 ancillary assigned. Our ancillary consists of EDT, which stands for Emergency Department Technician, PCA, and then transporters. The difference between the techs and the PCAs is that the techs are EMTs. So they can help cover our telemetry room and do tele runs for our patients. So bring them up to the floor if they need to be on telemetry or the ICU. So there's also triage, charge, and mobile. The triage, like we discussed, they're out in the front doing triage. You have your charge nurse, and then mobile is a position that's pretty unique, I would say, to even our emergency department. It's like a mobile charge nurse. You're an extension of the charge nurse. It is extra training that you do, similar to how you do extra training to be a charge nurse. And mobile's job is really to make sure that the department is doing okay, like nursing wise, provider wise, that they're handling their patients okay, and they help to slot the patients from the waiting room and ambulance to each room. So you'll check in on your nurses and make sure they're okay to take another patient. And usually it's about every hour that you'll get a patient, give or take. They'll slot the patient there. And then if you need help with something, they'll help you line your patient and they help with the throughput of the overall department. So in each area, like I said, you will have your team. We all sit together. If you've ever seen the nurses, doctor stations, we all sit together, which is part of what I love about the ER is that if I need something, I can just turn around and be like, hey, room 6, patient Abatello is feeling nauseous. Can we do another dose of Zofran? And they're like, yeah, sure, order it, and we can pop in and do it. We have a really great relationship with all of our providers. The residency is 3 years long. A lot of them stay and do a fellowship with us. So we form a really good bond with them. I love the fact that you have autonomy to do a lot of stuff in the ER that maybe other hospitals or other floors you might not get the chance to do. The providers really value your opinion. So you'll get a new patient. Often usually the nurse is the first person to go in and see that patient. So you go in, you do your assessment, you'll get the workup started, their line, their labs, maybe you're drawing up the urine, you're putting them on the monitor, and then it's kind of up to you to go out and tell the doctor, like, hey, they're not looking too great. I think we should do X, Y, and Z. And a lot of times, once you build that relationship with them, they trust you. They're already putting in orders. You're sending labs, grabbing the fluids. It's a seamless process. And it's really nice that you kind of have that clinical judgment that you can share with them and not have to feel like embarrassed or judged or like bad if you're maybe wrong about something or they don't agree with the plan. It's never a situation where they put you down for it. It's always a big learning environment, I would say. It's a teaching hospital, but especially in the ED, I feel like we're all learning a lot from each other. Um, so yeah, that's one of the things that I really love about it. And I feel like I've been a preceptor for a few years, and I feel like as a preceptor, I've seen myself grow so much in my clinical practice, and just bouncing ideas off of all of each other has been really nice experience. Yeah.
I think that's extremely well put. And that's just an overview of a little bit of what we do down there. We also don't have specific beds, like rooms. So when you come in the morning as the nurse, you go to our board, which is in front of our charge desk, and it shows your assignment. So it's a nice thing about the emergency department that you're not doing the same thing every day. We have a rotation through these different areas that the A&Ms and managers keep track of to try to give you, a different view each day. So you're not in gold every day. Our triage nurses have to be there for 2 years. So you then get trained for triage, and that's another area that you have the opportunity to rotate throughout the week, which is really nice. It's just it's a change. As well as our charge and mobile, they're usually there for even a little longer than that, 3 years or so. Where you can, if you feel like you want that opportunity, there are opportunities of growth even inside our department. So mobile and triage and charge are just trained areas that you get to expand to. So every day you come in, you check the board, where am I today? Okay, I'm in gold, or I'm in triage, or even covering breaks. So we do have assigned break times if staffing allows, which majority of the time it does. So you do get your hour break from a break nurse where you are able to step off the floor, de-escalate yourself, unwind, take time to eat, and then go back to the floor where your patients are being covered by a dedicated nurse, which is really nice. That's it. So we have a lot of different codes in the department, and some of them are used throughout the hospital, but they may look a little different to us. We have code sepsis, code EKG, code strokes, code gray, code ACLS, aviation, Sky Health, and Hello Care. So our code sepsis is obviously a big thing throughout the entire health system, as well as in the emergency department. We need to meet certain metrics for our sepsis patients because based on research, we know that meeting these metrics have better outcomes for our patients. Every metric that there is, everything that somebody's tracking you down to educate you on is for the purpose of better outcomes for our patients. And that's why we're all here. So our code sepsis, what we've done in our emergency department is we have an orange sheet. So once they're identified to meet SEERS criteria in our triage area or even during their stay, they get an orange sheet that just triggers the nurse to follow those metrics. To get the fluids up, to get the antibiotics within an hour, even vital signs after your fluids are completed, your lactate. So if your lactate's over 2, you need a repeat lactate. Just prompting you to remember those steps. Especially because in the ER, like Courtney was saying, you may get a patient every hour. Your patients are at different points of their stay. So you're constantly reprioritizing your day. You can't really come in the morning and say, okay, this is my plan for the day, because that doesn't work out. You're constantly reassessing your plan based on the types of patients you have and what your priority is for that moment. So that kind of keeps you on target for meeting those sepsis criteria for that patient. So you may have somebody who, just came in and is really, really sick, and then you have to go back to this patient, somebody who's waiting to be discharged, and there's just a lot going on at once. Our code EKGs are our chest pain patients. These patients come in with some type of cardiac issue, some type of cardiac complaint. So we have a policy that we do 10-minute EKGs. So anybody coming in with chest pain must have an EKG within the first 10 minutes on arrival. So we do have an EKG room in our walk-in triage area where our ancillary staff that is dedicated to triage for that day will do the EKG. So that's upon the nurse also to assess the patient, recognize the need for the EKG, and then send them to the EKG room. Once the EKG is done, our ancillary takes the EKG immediately back to one of our providers who reads it in real time and then checks it off whether the patient can wait in the waiting room or needs to come back immediately. So that's our process. If the patient comes in by ambulance, we call a code EKG overhead. So just like your system that you hear in the hospital of different codes, we have our own system in the ED that only can be heard by us. So we call overhead, code EKG going to Courtney and Gold. That way, on the way, when EMS is walking them over there, Courtney and the ancillary and the rest of the team knows that the 10-minute EKG, they get the room set up with the monitor and everything. Our code strokes. So obviously a stroke can happen anywhere. There's code strokes on the floor, there's code strokes in different areas, but we get a lot of code strokes coming into our emergency department. So this may be a pre-notification of a code stroke. We have a phone at the charge desk that any EMS providers can call to let us know that they're bringing a patient in that's It really means that they're getting a fast track to CAT scan. The goal is to get them to CAT scan quickly to evaluate whether they need some type of intervention, if they're in the window for it, or if, they can go to the side and they can cancel. So when we call a code stroke, we call the 5555 number. The neuro team comes down. The patient goes directly to CAT scan. So the patient can be in a wheelchair, their family dropped them off, and we're calling code stroke, going to CAT scan for Courtney and Green. So the patient goes directly to CAT scan. And then the rest of the team is kind of forming around that, right? Everybody jumps in and does their part. The ancillary may be getting the scale, just in case they need to. The nurse is grabbing a bag to get an IV started while they're sitting in a wheelchair outside of CAT scan. The attending is doing their assessment until neuro gets down, deciding what type of diagnostic testing they may need, how invasive of a CAT scan they need, and all that. Code ACLS. So we've all heard of a code blue that may occur maybe outside of the emergency department. And we call a code blue if somebody in our department who's, but we are our own code team. So we do our own types of codes. We run codes down in the emergency department all the time. A lot of the time, again, we get a pre-notification from what we like to call the bat phone to let us know that we're having a patient who's coming in, a little bit of their story, how long they've been down, has CPR been started, are they intubated, what kind of meds have they gotten, was it witnessed, and things like that. Other times, the patient may be in a regular area and we're not expecting it, and they can code and we can run our codes in there. Our codes, because we do it so often, I feel like go pretty well for us because we all know what our roles are, and I'm kind of going to go through that on a separate slide. Code aviation and code sky health are helicopters coming in. So the reason there's two is because they kind of trigger a different team to respond. So our code sky health is usually a patient being transferred from another facility. It could also be an organ. And that doesn't necessarily need a nurse to accompany the ancillary to take the stress. That patient will go straight to the ICU or straight to the OR, or sometimes, like I said, it's an organ. I've gone up to the helicopter and they just bring out a box. So it's somebody's liver transplant. So we are doing a lot of transplants here now, especially with the PSP building opening. So sometimes that's emergently how it gets transported to us. Whereas code aviation is an outside source of a patient that needs to come to the emergency. Most of the time, those are trauma patients. So it may be somebody who motorcycle accident, somebody who was on a boat who was found in water, or somebody who needs emergent care and needs to come directly to the emergency department. So we do run through training sessions where we practice going up to the helipad. Security is notified. They hold the elevator for us. You can only get to the helipad with their assistance. So they take us up there. We have a room up there that has jackets because it's freezing on the helipad. We have a stretcher up there. And our staff is taught how to bring the stretcher out safely. We go up a ramp. There's no railings up there, surprisingly. So we are trained how to wait for the helicopter to signal us over. We have to wait behind a certain line. If it's an emergency, they don't even shut off the blades. So we have to walk under it, and we're just being prepared. So we are trained on that, which is. But those patients are normally really high acuity. We need to get them down to the emergency department. Phone call letting us know that they're coming. And then our team goes up, and our team down in the emergency department will set up our trauma room. They'll get prepared on whatever they think this patient may need. Talk a little about trauma too. And then we have Code Hello Care, which is something new for our department. In some of our rooms, we're piloting this Hello 2 program. So there's cameras in the room that are live feed into a computer that one of our ancillary members is monitoring. So this is for our patients who are maybe a little bit confused, a little less than a one-to-one. So instead of taking all of our staff and putting them on one-to-ones, they're easily redirected. So the member of the team who's watching those monitors can watch up to 6 patients at once. And then they can also talk into the room. So there's pre-recorded buttons they can press, like please sit down. That comes in a few different languages as well. Or they can actually go into the room and press the button and say, help with something. Oh, I need a bedpan, or okay, please sit down. I'll get staff to assist you. So in that case, or in the case that somebody is getting up and isn't redirectable, they can call a code Hello Care overhead to our department to let some of the staff members know that there may be a need. Okay, what am I doing? So I'll talk a little about trauma. This is my favorite part of working in the emergency department. These pictures that I took with my phone are actually in the wall, on the wall, this picture and this picture in our trauma room. So like Courtney said, we have 4 trauma bays and they're all set up similarly. Have D, which is a little bigger, but A, B, C, and D. Each of our trauma rooms has a code card, has an airway card, we have 2 with Roslow cards, we have 1 with an OB card, and then we have all the equipment we would need for a trauma or a code ACLS or anybody who may come. So our traumas, every single one of our nurses has a trauma course, TNCC, ACLS, PALS, and TNCC. Which we go through, which is a 2-day course to go through the systematic approach of a trauma. So we do primary survey, secondary survey. What is your role in the trauma when you do attend? So when a trauma is called overhead, it can be activated based on our criteria, and these are a 3-tier trauma activation guidelines. So mostly we call a level 1, which is our highest acuity, and our level 2, which is our modified acuity. Level 3 is really just a consult. Maybe that's a patient who was on the floor in the department and then they found out from the family that they fell. Maybe we just want to have a trauma consult as opposed to a full entire trauma. So we try to run through the systematic approach for each patient. And the more we do it, the more we get used to doing it. So we have different roles there. We have our EM attending, we have our resident, our monitor, we have in our level 1 traumas, we have at least 3 nurses in there. We have 2 nurses at the bedside and 1 scribe nurse. The role of our scribe nurse is really important, documenting all the time. So they use this sheet to document the primary and secondary survey. And it allows for them to verbalize any treatments that have been done, if we need a recap, if we're ready for some type of intervention, or if they skip a part. So while the trauma team is going through the primary assessment, maybe they didn't see the pupils. So verify pupils, and they have this systematic sheet that kind of guides them. So during our traumas, closed loop communication is anytime there's any verbalization of either a finding or a need for something, we're always doing closed loop communication. They're shouting it out for the scribe nurse to read and also for the team to be all on the same page. Goals are given to everybody as they walk into the room. So not only is the nurse documenting up here which team members arrived, because for level 1 and level 2, there's different team members that get pages. So as they arrive, they get listed on there who was there for the trauma, as well as they get a sticker to identify who they are, because we are gowning up. So everybody's gown on. So on top of the gown, it has your sticker, so you can be identified as the team member, so that everybody knows what their role is. Our traumas are also, level 1 traumas are recorded. So every level 1 trauma is recorded in our trauma bay, and we use that for learning purposes. So we have trauma reviews every week where the trauma team comes down and plays. The purpose of that is to anything that may have been missed, anything we could do better, anything we did great. And it's allowing us to self-reflect or reflect on, any improvements we can make to our trauma. Different disciplinary teams meet at that trauma review. So we'll have nurses, we'll have ancillary, we have the trauma team, we may have OR people. Anybody's really invited, and it's a really good learning experience. About that. All right, so another big thing in our department is our code ACLS. So along like trauma, we also review our ACLSs. So all of our code ACLSs that occur in our trauma bays are recorded, and we have ACLS review. So a few of our doctors run that, and we come together to view, go over it together, decide, what we can do better, what, went wrong, or what we did great. And a lot of times it puts a different perspective on it. Like you'll watch the video and you'll think you slipped that Lucas in really fast, when in time on the actual recording, you can see that 10 seconds is really fast and that we were actually off the chest for 25. So things like that. And we talk about how we can decrease our time, how we can stay on the chest longer, what recommendations people have. So it's a really good team approach to improving all of our policies. Just like if there was a code on any floor, we do use our cardiac arrest data sheets, except that we don't have the clinical whatever impact team to come to our codes, because we are our own clinical impact team. So we have a nurse that does the scribing for it. That nurse, again, is super important for communication. This is the nurse who's keeping track of the time, who's saying every 2 minutes we need a pulse check, who's saying every 3 minutes or every 4 minutes we need an epi. Maybe later on into the code, the doctor says, let's pause for a second and decide, are there any other options for us to do? How many epis have we given? How many bicarbs have we given? How many calciums have we given? How have they gotten blood? Things like that. So it's a really important tool for us to ensure the best patient care. So we also brought with us our Lucas device. We're going to show you how we put our Lucas device on and what it does for us. This is not something that we have on other floors. It's something special to our department. You want to do it? So our Lucas comes in this cute little backpack that I carry here, and although it looks really cute, it's actually 15 pounds. EMS also has Lucas devices. So sometimes the patients who come who were in cardiac arrest may already be on the Lucas. So the Lucas has a lot of help. It does the and it also frees up one of our members getting tired, can actually take a break. And one of the important key things for our Lucas is that we don't take time off. From research that we should not be off the chest for more than. So normally what we do is if they're already in, and we board and we push out our Lucas apartment, and we are just putting this on. We try to work under during one and then continue CPR, so we're not taking full step. We're going to start early.
but we don't stop. We continuously do what we continue to do manual compressions while we are pausing to do other things or to re-measure and put it back to it.
So that includes the medications, but also the pulse check. In all of the rooms, we have a clock that has seconds on it as well. So you need to be watching that to make sure that you're not going over the 10 seconds. And like Diane was saying, everyone in the room listens to each other's voice. Everyone's voice is valued. So especially when you're in that position, you want to make sure you're on top of things. But the doctors always at the end will ask, does anyone else have any ideas, any thoughts? Did we miss anything? And then we also have the pause cards. Do you guys have that on your units? If not, ask patient family centered care. It's just a little card. It looks like a business card, and it has like a saying on it that you can do after you call time of death when a patient passes. And it basically just acknowledges everyone's hard work during the code and says like this was someone's life. They were loved by people, and they're not just a body. Basically, like this person meant something. You just take a minute to pause and give a moment of silence. So especially in the ER, when sometimes people come in from the scene, we didn't form a relationship with them. So it's nice to give yourself that time to appreciate your hard work and the fact that this was a real human person.
Right. So moving a little forward, some of these things I already talked about. We have a lot of education. That's why we have Rocio and myself. We also have 230 staff members in our emergency department. So we're a big, big department. We have fellowships. The next slide talks a little about our fellowship. We have residents. We have different residents, EM residents, trauma residents. We have our ultrasound residents. We have paramedic students that come in and do some training with us as well. We have capstone students. We have nurse extern wish days. So anybody who's finishing up nursing school and maybe wants to see what it's like to be in the emergency department, we welcome them to come down because sometimes, your view of it is not the best. You need to come down and actually see what goes on down here. We have IV champion rotations. So anybody who's starting the IV champion project comes down and spends a few hours with us to get training on IVs because we put them in. So a lot of times we send them out to our quick doc where they can just throw lines in, practice, and get some hands-on experience. We have a lot of debriefs. And like I said, they're similar to our trauma reviews and our ACLS reviews where we're going over how did it go? How are you feeling? What could we have done better? What did we do great? Sometimes acknowledging a fantastic team member. Sometimes saying, there was an equipment malfunction and nobody said, I need help. Just ways of improving. And then we have skills fair, which is going on currently. We have a lot of equipment in our emergency department. We're constantly getting new equipment. We're constantly reteaching some things we don't see for a really long time. And then, we see waves of it. So Rocio and myself hold our own ER skills fair. Right now we're doing A-line training. We're doing LVAD. We're doing Tenecta. We're doing our regulatories, our CPR, our restraints. We also have different restraints in our department because we use stretchers and we have a lot of psych patients. So we have 4-point restraints that have a key and a ball. A lot of different skills training with our staff to make sure that they're up to date, that they're refreshed on it, or they're seeing new skills for the first time and need to get their hands on. So our fellowships, we hold for a year. This lovely picture is actually some of our members of the audience.
Moving on.
So each of our fellowships is like a little family. They give themselves a name, and we go through numbers. So 63 is joining us right now, our Crash Cart Cuties. And they really do form a bond like a family. We also have our other fellow, Elijah. He's our current fellow. And 90, I'd say 90% or even higher percent of our staff have went through our fellowship. So everybody understands that the newbies are coming in, they're going through a fellowship, they're going through this program. So we have 3 phases. Phase 1 is 10 weeks. We do simulation, we do echo modules, we do skills training. We go through didactic portions. We basically run through the body systems as it relates to emergency situations. And then we go to simulation with other hospitals and do some, you know, judgment-free education there. Phase 2 is when you go with a preceptor. So you have your preceptor, you're on one of our 4 shifts, 7A, 11A, 230P, or 7P, and you work with a preceptor, you're following them, you're taking patient loads. But our main focus of our fellowship is critical thinking. So like Courtney said, we have a lot of autonomy in our department, which is amazing, but you need to back that up with education. So we're really focusing on what is the theory behind what we're doing, and then how do we put that into play and take care of our patient using that knowledge. So everything we do, every time we're following up with our fellows, we're saying, why did you give that medication? What is the goal of that medication, and how did you evaluate it? So we're really thinking, not tasking. We're not reading an order and just doing. We're reading an order and saying, what is our plan for this? Why are we giving this? What is it going to do inside the body to help our patient? So that is really our main focus to our fellowship. And that's why it takes so long, because it's not just this or just that. It's everything. Every single day, there's different patients that come. You can work down there for 40 years and you still get something you've never seen before tomorrow. And then we have phase 3. So after your orientation on the floor, you complete the year on probation with resources. And during phase 2, you also go to Cohen's for 2 weeks. To get some hands-on pediatric training. So with all that we've went through, we do recognize, and our leadership does a great job recognizing that this is a really, really stressful job. So these codes that happen, they can happen to your patient when you have 6 other patients and you have to see a grieving family member and then walk out and go take care of your other 6. Not easy. It's very hard work. There's a lot of emotions that go into this. We don't ever get used to having a patient not make it. We also have some really tragic events that happen, some traumas, ACLSs. So it takes a lot of toll on your mental health. So our department is really, really aware of that. And they have all of these things in place to make sure that our staff as humans are also taken care of, which is really the reason I stay in this department, because we really are cared for. So we have a wellness team, which is a lot of different members of our team that do wellness events for us just in our ED. Maybe we have a really high census or something really terrible happened and they come around with ice cream and we get cookies or iced coffee or just something to brighten your day. Maybe a sticker, something that says, hey, we see you. Maybe you need to take a second for yourself, right? We also have our PFCC program manager, who's Cynthia. She's my favorite. She works with us and us only. So she, at any time there's a tragic event, you can message her and say, you know, I think that Courtney is having a tough time. Will you check on her? She personally checks in on you. She gives you resources, and she's call her in real time. We've had her come down and do Reiki with us because we're stressed. Or she comes down and gives those little scent pens that, you know, maybe just you need some lavender. And she's always there for our mental health. She also checks in on patients. Anybody who's, you know, maybe has a complaint or is not having such a great day, checks up on you. So we have a collaborative care council, a retention committee. How do we get our staff to stay? Our staff has a lot of say in what we do in our department. We run pilots, we change things, really take their feedback and use it because they are our first line. We have a Zen Den, which came out of our wellness team. So it's a little area that's not the break room, that has some recliners, and it smelled really nice, and they have books and just a relaxing place that you can step off the floor. And mental health day, So it does use your PTO, but if you're having a rough shift, you're allowed one mental health day a year, and you can go to A&M and say, tomorrow I'd really like to use my mental health day. We let one person use it a day in each of the shifts. So it's something really nice where, or they may say, hey, Courtney, I see you're having a really rough day and you still have your mental health day. Why don't you take the day off tomorrow? And so it's really nice. We have our Pebbles project. This is really new. We have QR codes around our department. I'm trying to finish up. That if you're having a frustration, maybe something that's really bothering you, you can scan the QR code. It goes to a team of interdisciplinary members that we get in real time, and maybe we can solve it. So we have our Pebbles, which we can solve in real time, solve really quickly. Our rocks, which maybe take a few weeks, but we'll put into place. Maybe, we need an extra telephone at this nurse's station, whatever the case is. And then we have our boulders, which, may not be attainable. Can't have free lunch every day or, things like that. Or things that are just out of our control. And then cold lavenders, which everybody uses, but should use more often. Anytime you need a debrief, you can call it cold lavender.